So this is just an outline. I'm not going to define PSC, the treatments, monitoring, etc. Kate's already done that. I will talk a little bit about the differences between paediatric practice and adult practice, and also consider an alternative paradigm, particularly of paediatric onset disease, but perhaps a little bit into adult as well, and also reflect on the journey of children and parents. So I will be stepping away from what the adult gastroenterologists are comfortable with. Some of this, I think we can say, is assumed knowledge. And so this is a fetus in a sterile environment who is receiving all of their nutrition from their mother via the umbilical cord, also receiving some benefits from an immunological perspective from their mother. And then it becomes time to enter the world. I've used a bit of discretion here by the traditional method, or perhaps via the sunroof. And then there's, oh, sorry, that's gone one too far. So, and then you get to this point where the umbilical cord is clamped. And so it's really a case of saying, well, good luck with your immune system, by the way. You're now exposed to the world and all the bugs in there, and you have to decide what's good and what's bad. And also, by the way, you need to take all your nutrition and get all of your nutrition by mouth. So, yeah, this is a liver talk, right? So anyway, what we find is that obviously when you eat and drink, things go into your gut, and then the nutrients, etc., from your gut go through the portal system through to the liver. And that can obviously be a very good thing, but potentially can also be a harmful thing. So I'm just going to talk briefly about a few conditions, perhaps related to PSC. There's a condition called autoimmune hepatitis, which really affects the liver cells. So if you imagine the liver and the biliary tree is a bit like a tree, this really affects the leaves on the tree, if that makes sense. And most people with this condition do respond quite well to immune suppressing medications. Obviously, people here know about PSC, again, using the analogy. This is really affecting the branches of the trunk of the tree. There might be an autoimmune component, but generally speaking, immunosuppression really isn't too helpful. I know Kate didn't mention that, and that would be our experience as well. There's another condition I'll sort of introduce called autoimmune sclerosing cholangitis, or it's otherwise known as overlap syndrome. And the concept of this is that the autoimmune hepatitis and sclerosing cholangitis don't exist independently. They're really part of an overall spectrum of both disorders, and people sort of fit within that spectrum. And just looking here, I don't know if my mouse, it doesn't come up on the screen there, but various different ways of looking at it, whether it's a true overlap, whether there are three independent conditions: autoimmune, overlap, primary sclerosing. I think the middle ground one is probably the best one. And obviously there are a number of people at each extreme of this who have either autoimmune hepatitis or primary sclerosing cholangitis. But particularly in pediatrics, we find a lot of people in the, I was going to say the grey zone, it's the coloured zone there, but in the middle section there. So just looking at this as pictures, this is autoimmune, sorry, I'm moving on now, immune-mediated hepatitis, or autoimmune hepatitis on the left-hand side as you're looking at it. And then on the right-hand side, we have primary sclerosing cholangitis, and in the middle, we have overlap syndrome, or autoimmune sclerosing cholangitis. And we find that over time, at least in the pediatric age group, and probably going into the young adult age group, we do see people who start off more as an autoimmune hepatitis type presentation, moving into this sort of overlap syndrome or autoimmune sclerosing into the middle picture there. And then perhaps onto the last one. You can see the arrows there, the filled in arrows versus the dotted arrows. Also the link with inflammatory bowel disease that Kate mentioned there. we tend to find that people on the left-hand side of this diagram, the autoimmune hepatitis, and this is not exclusive, but generally speaking, many more of them have a normal colon, don't have inflammatory bowel disease, and those perhaps trending more towards the right-hand side of the screen there do tend to have, much more often than not, inflammatory bowel disease, with ulcerative colitis more common than Crohn's disease. So looking at the current concepts, we know that adults with primary sclerosing cholangitis, between 6 and 14%, have features that might fit with autoimmune hepatitis. So in this cohort, perhaps even up to 10%, perhaps something like 50% of children have features of primary sclerosing cholangitis in this group. And as I said, the incidence of inflammatory bowel disease with autoimmune sclerosing cholangitis does firstly increase with time, and secondly does increase as you move along towards the primary sclerosing and perhaps slightly away from the autoimmune hepatitis picture. So what does this look like with the first consultation? So a GP's referred child with liver function tests that are perhaps a little bit off. That might have been done to look at something totally different, or it might have been done for something like fatigue, for example. Probably not, but possibly they may look a bit yellow, and when you examine them, they might have a big liver and a big spleen. And when you ask about it, or they might volunteer it, but when you ask about it, perhaps they do have some bowel symptoms, perhaps even something as obvious as blood in their stool, but often not. And so at that point, you'll talk about the most likely diagnoses. You'll almost certainly at this point need more tests, whether it's blood tests, stool tests, maybe urine tests, imaging tests. And usually at that first appointment, you'll be able to provide some sort of guidance along the lines of, look, I really think these abnormal liver tests probably aren't anything too bad. They're probably going to get better, but we'll still monitor it. Or, look, I think this is actually something pretty significant, and we're going to have to really look into this more. And there is a very real chance that we're going to find something that will need some more monitoring, etc. So on the left-hand side here, this is the people who are referred with, if you like, a liver presentation of this. An alternative referral is perhaps the GP refers with primary bowel symptoms, maybe blood in the stool, etc. And GP might have done liver tests and they're a little bit off, but nothing too bad. Ultimately, this person might end up having inflammatory bowel disease and primary sclerosing cholangitis or overlap. But it's really in that case, you might look at the priority as saying, well, let's perhaps sort out the bowel side of things first. We'll do some other tests to monitor and look at the liver side of things as well. So in my practice, this is how patients may sort of come to me, and how this sort of early diagnosis may go. So then once you've done the subsequent tests, once you've got all the information, the consultation can sometimes be difficult and challenging in the lines of just talking about that whole overlap and the shades of grey, etc. I might say to the patient, look, this is, I think, what you have, but be aware that with time it might sort of change a bit and I might change my mind. And even though I'm talking, these are not the words I use, even though I'm talking about offering a treatment now, might be if things change, there might be something else that we need to do. And then by that point, the patient's asking questions and they're saying to you, yeah, but surely there's something you can do that's going to really change this. And if it is this sclerosing cholangitis, there's got to be a treatment for it, isn't there? And that conversation is difficult as well. Kate mentioned you can talk about things like URSO, which changes the biochemistry. Does it definitely change the overall outcome? Maybe, but also maybe not. And then comes to the difficult words of liver transplant. You say that word and you can imagine with a child who 3 weeks ago, 6 weeks ago was really a bit flat, but perfectly well, comes in, and then you're talking about all of this sort of stuff. And then if there is an autoimmune component to it, you can introduce the concept of look, maybe we could try using some immunosuppressive medications. Is that going to help? Well, it might make your blood tests look better, might or might not affect the overall progression of your liver disease or ultimately the need for liver transplant and that sort of thing. And are there any side effects of immune suppressing medication? Yes, it might make you more prone to infection. It might make your liver tests a bit worse. And then the patient's just going, you've got to be kidding me. What is this? What have I walked into? So it really has to be a very careful conversation with the probably more often teenagers, sometimes younger, with the patients themselves and also with the families. And I think you have to walk them through this process in a very careful and gentle way to, I think, keep them engaged. And it's really a case of making decisions together and discussing what the options are and what you can do. But I certainly share Kate's view that we're all sort of crying out for much more to be done. And from a paediatric perspective, we would love for some of these treatments, if they become available on the to adult gastroenterologists, to become available to us sometime inside of 10 and 20 years. So yeah, that's really the paediatric journey, if you like. So the whole concept of reframing paradigms and thinking of conditions in a sort of a slightly different, perhaps non-traditional way. We could use the analogy of inflammatory bowel disease. So inflammatory bowel disease sort of has two conditions, two main conditions, if you like. It's ulcerative colitis and Crohn's disease, and then IBDU, which some people say is a separate condition. Some people say have features of either, but you can't be too sure. But we do, I think in the IBD world now, inflammatory bowel disease world, we are very comfortable in people who have IBDU having the conversation to say there may be more information that becomes available, which perhaps means that your disease declares itself as being Crohn's disease, or this particular disease in you declares itself as being ulcerative colitis. And if that were to happen, it might be that there's a different treatment for you, but it might be better than the one you're on at the moment. So I think the autoimmune hepatitis, autoimmune sclerosing cholangitis, primary sclerosing cholangitis spectrum is somewhat analogous to this. So, hopefully through collaborative research, we will be able to reduce the uncertainty and obviously help all of our patients who have these conditions. So that's really all I've got to say, and obviously questions for later.